operations. We had done a preterm VSD closure. We had done a preterm 2 kg TAPVC, total anomalous correction, a coarctation of aorta repair, and two infant VSDs. These were the smaller kids. And of course, we had the older, but predominantly it is the lesser than 1 year of age children who are being referred of late, and this thing. And also the last child, this was a child who had acute rheumatic fever with acute caudal rupture, who was very sick, and he had arrested, we had to replace the mitral valve, and he's actually on the ECMO. So that this is the current list of the patient, a few patients which are there on our in our ICU. On the intervention front, yeah, we do newborn interventions preterm, as you can see, baby who had a very bad X-ray on the right side, which you say it's a 2 kg baby. So like it just had a large patent ductus arteriosus, but the child was really sick. Instead of doing this thing, we closed it transcatheterally, and within few days the X-ray improved. So we have an advanced or the best low radiation advanced equipped Philips cath lab, which is exclusive to us. And we do about every week or every month about 40 to 50 transcatheter procedures as of now. We also do the adult structural interventions because we have. One is little bit of exposure to that, and we are more used to do the manipulation of the guide wires, and anatomically we are little better. So they do keep getting referred to us. So we do these surgeries also. So our preterm interventions from 1.1 kg babies to an adult, sometimes when there is a need, and whether if a adult cardiologist referred to us a structural intervention, a ruptured RSOV, or a ruptured ventricular post-MI VSR, ventricular septal rupture, those are also life-saving. Those interventions also we take up sometimes in our cath lab. The success is we are a team. So we do, all patients are we collective amongst ourselves. We take the team leader in the ICU also is there in the this thing. The head nurse of the whole hospital, she also is with the nurse, with us in the rounds, the respiratory therapist and the medico-social worker. So we have a collective rounds every day, and it's a team job. As far as our inventory is concerned, we are lucky to have good supporting machines, like 3 heart-lung machines. So because we have 3 operation theaters, we have 2 ECMO machines, 1 CRRT machine just in case of renal failure or those post-op patients. We have an exclusive cath lab, 2 high-end echocardiography machines, and a portable machine so that we can do CAMs, and also TE probes. And we have our own central sterilization department so that we don't have a cross infection with the other hospitals. So looking at this, the TTD officials and the government were happy with what we started off. So we put forward a proposal saying that we needed more beds and other specialties. So there is a need for treatment for thalassemia patient. We need a bone marrow transplant unit. There are a lot of patients. There are some patients suffering from renal problems. So pediatric nephrology was also needed, and other gastroenterology. So they agreed to our proposal when we put forward, and we have planned 4 lakh square feet, 350 bedded pediatric super specialty hospital. The work the tender is completed, and the work has started. We hope it's ready in the next 12 months. So having all the other specialties of this thing, pediatric subspecialties right next to our hospital, is through a distance away from us. And we have planned it in such a way that in future we also have a helipad for having an air ambulance just in case for transplants or any transporting of a sick patients.
Sure.
So this is our ICU with the nurses team, the cath lab, the echo technicians team, the OR, the OT complex, all the supporting staff, the fellows, the young doctors who are always there, doing twice the night duties and round the clock covering the services. They're all young and energetic. Our team predominantly, all of that, put them all together. Dr. Ganpati, who is our pediatric head cardiac surgeon, the left on top, and Dr. Dipesh Trivedi. They do predominantly, they are senior and they guide the others, and they run, they pull the team together. And Dr. Soumya, Dr. Madhu, and Dr. Abhinav, they are all young cardiologists, anesthetists, cardiac surgeon, who binds and keeps giving us the adrenaline to the older people and catch the juniors also. We are a team, so gradually people have next one on one, they have joined us, and the team is growing, and we are able to do better this thing. Yeah, and we have few eminent people visiting us, philanthropists like Dr. Sudha Murthy. She came and she has visited, and she has promised to build a patient outreach tree for the chairman Pratap C. Reddy of Apollo Hospitals. He donated the ECMO machines and machines required for heart transplant. Few machines, high-end machines, which we once on their own, they just saw the unit and they have just donated. So, concluding, most of the time on the day when they go home, the patients on that day, after they would generally take a group photo and share, irrespective of religion or this thing, any caste. The Devasthanam support everybody, and whoever comes is offered treatment for congenital heart disease. So, as of now, we have done 1,000+ procedures in the last about 14-15 months since we have started. We are thankful, and with the blessings of Lord Venkateshwara, the program is running well, and we have been successfully treating a lot of patients with a very good success rate. With the blessings of the Lord Venkateshwara, our success rate is as good as one of any centers, reasonable centers in the West, with the success rate of more than 96%, taking up all the complex cases. Yeah. Thank you.
Thank you so much, Dr. Sringareddy, sir. Really doing the God's work. So we have no words. So I will move on to the next speaker. I'm going to introduce Dr. M. Srihari, sir. He's from Kerala State Child Health. He's a medical graduate with more than 15 years of cumulative experience in the public health. He's state nodal officer in the National Health Mission. And he conceptualized, implemented Hridayam for Little Hearts, a highly successful project, an initiative of Government of Kerala State, improving access care for children of CHD. And he played a leading role of pulse ox for every newborn screening in the state of Kerala. So he worked as state RMNCH plus a consultant, UNICEF, Kerala from December 15th to 27th. He's a district program manager from 2010 to 2015. He's achiever of Chief Minister Award Kerala for the best citizen service delivery system for the Hridayam for Little Hearts in the year 2018 to 2019. E-Governance Award for best citizen service delivery system in 2018 for Hridayam for Little Hearts program. We'll hear from him. Sir, Doctor, can you, Dr.
Yep.
Yes, sir. Oh, awesome. Thank you.
Can you hear me?
Yeah, yes, sir. You can share the screen too. I will make you co-host.
Thank you.
Yeah, I think you can try to see. Yeah.
Yes.
Can you see whether you can see? Yeah, good.
Am I audible?
Yes, sir. Go ahead, sir. Thank you so much for coming. Appreciate, sir.
Yeah. Thank you, AAPI, for inviting me for this wonderful program, and it's a privilege. So, Dr. Srinath Reddy has already set the platform, and he was talking about the need for infant surgeries, and that is what we tried. And he was talking about the difficulties for any government to chip into the pediatric cardiac arena, trying to save infants or neonates. Yeah, it is true. Even in India, even in today in India, pediatric cardiac surgery and pediatric cardiology is a matter of passion and commitment from the side of pediatric cardiologists. That is what we are seeing. And even though there are multiple corporate institutions in India operating, that is not going to make much difference if government is not going to chip in. So that is the point. The government of Kerala has thought about investing in pediatric cardiac surgeries. We had a reason for it, and I'll be talking about it. And we have developed a program. Maybe I'm not saying it is a total end-to-end solution, but we try to involve everything, incorporate all the possible aspects, and still we are developing from the point every day. So we put the name Hridayam for Little Hearts. That is the program name, and we started in 2017. The first cases operated in 2017 August. So as we know, India has improved a lot, especially with regard to the infant mortality. We are trying to reach our SDG target. Still, we are reducing, but Kerala was a forerunner, as all of us know. Our IMR was infant mortality rate was 12, even in 2000. So, but it was stagnant for more than 15 years. It was 12 from 2000 to 2015. And the political leadership and administrators started asking the question, why it is not reducing? And the technocrats like me had to give a lot of explanation. And we were asked to come up with something or tell the reason why. So that is where we looked at the infant mortality rate in a very purposeful way, and we found that our infant mortality was mostly due to prematurity, birth asphyxia, and one of the leading causes congenital anomalies. So out of the congenital anomalies, more than 60%, 54 to 60% are due to congenital heart diseases. So we were able to tell the administration and the political leadership that if you want to improve further on your infant mortality, you will have to work around congenital anomalies, especially among the congenital anomalies, congenital heart disease was found to be the low-hanging fruit. And it was low-hanging only because we had a legacy of having some institutions like Sri Chitra Tirunal Institute in the southern part of our state at Trivandrum, and some private sector institutions, the major contributor like Amrita Institute of Medical Science in Cochin. And there were some other private institutions who were who will be also a major player in our program. So that was the decision that we took, and we just analyzed what is our the entire scenario in the state. We found that we know that we have around 500,000 births every year. Out of that, we are going to have around 4,000 cases, and out of that, 25% or maybe 30% maximum need a surgery in the first 1 year. And we found that at that time we were operating around 500 plus cases. Out of that 300, maybe 500 cases were operated by Sri Chitra even at that time. But out of that, there are around 200 cases from other states, and we were getting around 300 cases. Out of that 300, Sri Chitra was operating around 200 infant cases. And institutions like Amrita and other institutions, they were operating around 100 cases. We found that the institutions altogether, the centers at that time we had around 4 institutions plus 2 government medical colleges started doing cases. Altogether, they can operate around 10 cases per day in a single pool, and the limiting factor was money. People are unable to pay money in private sector hospitals. and the government decided to call for a meeting of all the hospitals who are operating, and they were very generous. Again, I must say that it was the commitment of the pediatric cardiologist and pediatric cardiac team that was instrumental, and they were all there present in the meeting, and the only thing they asked was for a government investment. And there was a program, even still there is a program in India, which is called Rashtriya Bal Swasthya Karyakram, RBSK, which has a provision to reimburse for the surgical cost if referred in that scheme. But the money that is reimbursing is not that high, but that is a good sum anyway. And the hospitals were ready to accept that sum, and we started the program. So when we designed the program, we thought we'll have something like this, a patient care continuum will be established. So that starts from recognition of case, then the confirmation of diagnosis, and we need definitely prioritize, because we had even at that time and even today we have a backlog. The older children, ASDs and others are still, there are cases waiting, and we need to have proper referral. Kerala is a state which is spread in a length of around 900 kilometers from south to north. And if a case needs to be referred from the northern part of Kerala to Sri Chitra, it was very tough. In a population density of more than 800, 900 per square kilometer, and the very high traffic and very narrow roads, it is very tough. So we thought we need to have a proper referral system, and stabilization needs to be done. That is again the trend. Every time when you have a case, if it is diagnosed to have a critical congenital heart disease, yeah, you need to shunt it out immediately. You need to transfer out. That was the way people were doing, and we took almost a year to teach all our pediatricians, or maybe the major hospitals, to keep the baby there, stabilize them. We will take care of it. So that is the assurance that we gave. And of course, the treatment part, and that is that there comes, it is the free treatment, whether it's an intervention or maybe a surgery. We identified that by surgery alone, or maybe the treatment that we are giving, that is not going to solve our problem. We thought we identified that we need a strong follow-up, especially a community level follow-up program. In the recognition part, we understood that definitely we need to have an antenatal screening program. For that, again, we trained our obstetricians and the radiologists to do a fetal heart screening. Because as Dr. Srinath was pointing out, there are cases like TGA with intact ventricular septum, or maybe it's very complex disease conditions that we may not get time to refer. Or they may not get time to reach a hospital. So we thought we need to identify the cases early, and in utero transport to the centers, make the delivery possible there, and take the baby for surgery in the first maybe 2 hours or 3 hours, or maybe doing a pass. So whatever it be, those sort of things we decided. We decided to go for universal pulse oximetry. That is again the suggestion from the experts that we had, the pediatric cardiologist, and fortunate to have a US-based NGO, Children's Heart Link. They were partnered with us through Amrita Institute of Medical Sciences. We did a lot of training. All these hospitals, all these people helped us in developing a transport protocol, stabilization protocol. So then the major challenge was how to prioritize a case. So again, that we devised a protocol and took the consensus statement that the pediatric cardiologists and pediatric cardiac surgeons put up in India. So all these things were adapted, and the patient care continuum was the backbone of our program. We stick on to this still. This is the Bible that we have. So 2018 we started the pulse oximetry. We were doing all this newborn screening even from 2012, being a state with the lowest IMR. We every time we were looking at the quality of life as a parameter for newborn survival and newborn survival. So then in later phase, we identified that pulse oximetry alone is not going to make our task easy. And we introduced a protocol for physical examination, focused physical examination, that is a CVS focused physical examination. We again developed a protocol for that and introduced that along with the pulse oximetry, and that improved our sensitivity for identifying almost all the congenital heart diseases. So this is the way that we do. We have 100 government delivery points, and all of them do the pulse oximetry screening and physical examination. And by the end of the day, all these data will be uploaded to the server and give alerts to the concerned stakeholders, so that there are n number of pulse ox fail cases that needs to be taken for echo, or maybe the physical examination somebody needs to see, and how many are seen, how many echo are done, how many new cases are registered. All these things are digitally documented, and this is the flowchart that we follow for the program. We have the left side. You can see the pillars. The cases can be registered in the web portal. The web portal is hridayam.kerala.go.in. Patients can register, the nurse can register, whoever wants, somebody identifies a case can register. Basic information, if the input is given, then the intimation will go to the district early intervention center. We have 14 districts, and all 14 districts have a district early intervention center. That is again another structure under RBSK. So they will check whether all the information are there. We need basic information, some echo findings, all these things. If they are available, then they will verify the case, and it will go to a panel of pediatric cardiologists and pediatric cardiac surgeon. They will give an opinion that basically prioritize the case. So something like we have a categorization, category 1, 2, 3. Category 1 means that needs to be operated in the next 6 months. So whenever the case registered, say like a VSD is registered at 3 months. So nowadays we operate all those VSDs requiring surgery before 6 months. We won't allow that VSDs to wait beyond 6 months. So that will be 1F. So similarly, there is a protocol we have, and accordingly the treatment plan will be put. It will be open to all the private hospitals or all the empaneled hospitals, including Srijitra and the government hospitals who are operating. And once they put the date, it will be alerted to the family. They can choose which hospital they would like to go. They need to give a consent, so that the consent is attached, and the case will be allotted to the empaneled hospital. The patient can walk in, they can go to the hospital, get treatment, and they can go back. And the hospital will be submitting the bill to the government, the districts, and the DACs will make the payment to the hospital. So this is a system that we follow. Immediately on discharge, the details needs to be entered by the hospital, so that the community level nurse, we have the nurses, we have RBSK nurses in all the Grama Panchayat. So one Grama Panchayat corresponds to around 30,000 population. So we have a nurse in all Panchayat. She will get an alert that one of your case, one of the child from your area is operated, or maybe an intervention done and discharged. So there is a protocol device for follow. The first follow will be on the 3rd day of discharge, then 7th and 15th, and 30th day the family will have to go back to the hospital, and there will be follow-up protocol for individual cases thereafter, according to the condition. So this is the way that the program is managed, and you can see the numbers. Every year the cases, the 2017 August only we started, that's why we had around 493 cases. So last year you can see there are around 4,700 cases registered in the system. Now we encourage everybody to register all the cases, whatever it be. Even if it's a small ASD, we are registering. This becomes a registry, sort of a kind of a registry, and the prioritization happens, and so we don't worry about all the cases getting registered. These are the type of the day-wise cases registered less than 30 days. That also you can see tremendous increase in the number of cases. The most of the newborn cases are identified in the newborn period itself. At least the maximum number of cases in 2022, you can see almost 3,300 cases registered in the first year itself. And this helps a lot in saving a lot of life, especially those cases usually we miss or we may not identify, and that the child may die even before getting diagnosed. So this is the strategy that we have adopted. The cases operated, yeah, that also you can see the numbers are increasing every year. 2021, there was a backlog for 2020 due to COVID, and 2022 you can see almost 1,250 cases either operated or intervened. Most of the cases are usually in the first year of life. Most of the cases are the maximum numbers are done by the Amrita Institute of Medical Sciences and the one from Calicut, the MIMS from Calicut, because we have maximum number of cases from northern Kerala, the Malabar. So, and Srijitra, of course, operates a lot of cases nowadays. In between, they were not part of the program due to some administrative issues, and that's why you can see that there was less number of cases in 2022. So this is the neonatal cases done. Every year we have almost same number of neonatal cases operated. And we have a follow-up program for both the pre-surgical cases and post-surgical cases. In the first and second year, we found that even though the cases are getting registered, we missed or maybe some of those children die before getting operated. So that's why we thought we need to have a pre-surgical follow-up program as well, and of course the post-surgical follow-up program. And this has improved the survival. The post-surgical follow-up program definitely has improved the survival, and almost all these children operated or maybe registered are on a monthly or maybe bi-monthly follow-up with our RVSK nurses and in the health system. So when we started, we never thought of making it as a registry. Now it's like a web-based registry. We know how many cases are coming from which all part of our state, what type of cases are getting registered at what point, and this gives a lot of information for us as a public health program to improve on